IMA, Academy of Medical Specialties, to start the proceedings. Also would request everyone to mute themselves and just allow the speaker to talk so that there is no disturbance during the webinar. Thank you.
Thank you, Sabkari. IMA Telangana, IMAMS Telangana group, as well as Association of API of the Hyderabad chapter and Advanced Mycology Diagnostic and Research Center, NIPS, Hyderabad. Thank you for inviting me as a chairman on a very, very pertinent and a relevant topic and fungal infection updates. We are all very bugged by the fact that the fungal infections are also developing a lot of resistance, and we really sometimes don't know what to do in the critical care. And so you've chosen a very, very pertinent things. And I'm sure with all the people joining, the seniors as well as the far and wide, they would really benefit from this topic. Without wasting much time, I'll just carry on. That it's time that we go straight to the academic feast that we are all waiting for. Thank you very much.
Thank you, sir. I would now request Dr. Naval Chandra, Chairman of the API Hyderabad chapter, to start the proceedings.
Good evening, everyone. It's an honor and a privilege to associate with IMA and also the ICMR, especially the wing of, the mycology at NIMS, who has taken up this initiative, and they wish to have a series of such CME programs covering different fungal infections. So I think we're looking at about 4 or 5 such CME programs. And to kickstart the first one, that's going to be on fungal, candidiasis, invasive candidiasis. So we've got 5 very eloquent speakers with us today. And firstly, so as we are aware, fungal infection, we're going to go right from the epidemiology of this particular infection into what the clinical scenario is, and then the treatment modalities, and finally end up with prevention of this particular infection. So I wish to invite our first speaker, and he's a very, very renowned and speaker, especially we've heard him on so many occasions in the infectious diseases forums and also in various national and international conferences. I wish to introduce Dr. Ram Gopal Krishnan, and he is a consultant physician and intensivist at Apollo Chennai. So he will be taking us through the epidemiology of this particular invasive candidiasis. So I request Dr. Ram Gopal Krishnan, sir, I request you to share your presentation, and we will begin your talk, sir.
Thank you very much. I hope I'm audible to all. Just give me a minute while I share my slides. Okay, hope all of you can see my slides.
Yes.
And okay, so thank you very much for setting up this series of lectures on fungal infections. This is an important topic, and the first in this series will be on invasive candidiasis and its changing epidemiology. Dr. Umabala asked me to mention a few words upon what we do in general, what are fungi in general, just a few general points about fungi. Yeasts are those fungi which look creamy and which disseminate on the surface. The commonest of medical importance are Candida and Cryptococcus. On the other hand, molds look fuzzy and they disseminate through the airborne route. Aspergillus and Mucor are the most common there. The dimorphic fungi behave as yeasts in tissue, but in culture plates, they behave differently. So they are slightly different. They have 2 forms. So the commonest in India are Histoplasma and Talaromyces, formerly called Penicillia. Now, these fungi certainly can be quite severe, and look at these mortality rates for these systemic fungal infections. They can certainly knock you down if you're not careful or you don't know what you're doing. So you have to be careful with these fungal infections. All of them carry a high mortality if not diagnosed and treated correctly. Now, WHO has set up some priority fungal pathogens, which are important to know about. Note the ones on the left, the critical group. There are two Candida species in there, Candida auris, which I'll spend some time on, and Candida albicans, the commoner one. So certainly Candida species are up there in terms of importance, in terms of medical importance to us practicing clinicians. Now, what is the Indian scenario? All of you see patients in your practices, and you know these things, but it's worth reiterating in relation to fungal infections. We have many susceptible hosts. There are 2.5 million people with HIV who might potentially get cryptococcus. There are 30 million diabetics who can get any fungal infection. ICUs are mushrooming all over the country, and we tend to use a lot of antibiotics, which often are unnecessary. Many centers are doing transplants, solid organ as well as BMT. There is a big problem with IVDU in certain parts of India, such as Northeast and the Punjab. Steroids are available, unfortunately, across the counter and used inappropriately by practitioners. And when you give an antibiotic-exposed patient plenty of steroids, that's like a cookbook recipe to develop a fungal infection. And if your hospital infection control is not good, that spreads from one patient to the other. So this seems like the perfect storm for a fungal infection. So moving on to Candida, which is the subject of my introductory talk here. Let's start off with a case. This is a very typical patient, which I'm sure all of you would have seen in your practices at some point or the other. 64-year-old male with acute necrotizing pancreatitis, admitted 10 days earlier. History of diabetes, CKD, and a seizure disorder. There's a central line in situ through which TPN is being given. There's a Foley in situ. The patient has been on Pip-Tas. Somebody started it, but someone forgot to stop it. And now the patient develops fever. And this patient is a little sick, as the intensivists would clearly recognize. There's tachycardia, there is some hypoxemia, there is hypotension, there is some metabolic acidosis, there is evidence of SIRS and early DIC. The renal function is worse, the liver has taken a hit. So if you don't intervene and make a diagnosis and start appropriate therapy in a hurry, you're probably going to have a poor outcome. So all of you who see patients in the ICU run through this differential when you see such a patient: central line infection, pancreatic infection, UTI, SIRS due to the disease per se. But it's important to keep in mind that this is the time when this thought of Candida should cross your mind, because if it doesn't, you're going to be in trouble. And as you will know, or as you will see over the subsequent lectures, it's important to do the appropriate tests to serum blood cultures as well as beta-D-glucan to make the diagnosis. And will you start antibiotics empirically or not immediately after recognizing this clinical entity? The correct answer would be yes, you will start antibiotics. You certainly are not, sorry, antifungals. You certainly won't wait for your culture reports. I'll show you why. Which antifungal, this will be discussed in detail in a subsequent lecture, but possibly echinocandins are the right answer. And blood culture flags yeast, you know you are in trouble, but it does confirm your diagnosis. If you give a narrow spectrum antifungal, perhaps your patient might get worse. Certainly this patient got worse. And no wonder, because the species we got on this patient was Candida auris. We'll spend some time on that, for which echinocandins would be the drug of choice. And it's important to do certain other things in these patients. You need to look into their eyes, you need to repeat blood cultures, you need to de-escalate the antifungals and treat for a couple of weeks. At least all this will be discussed in detail. So our patient finally got started on an echinocandin, the line was changed and recovered slowly over the next 1 week. The fundoscopic exam was normal. It's a very typical patient in the ICU who develops invasive candidiasis. So what about the epidemiology of invasive candidiasis, which is the topic of my lecture? Now remember, all of us carry Candida in our bowels, and it ordinarily does nothing to you except when you get antibiotics, which wipe out the bacteria, especially the anaerobic and the gram-negative bacteria, and bowel flora grow out. Now, this is increasing in incidence worldwide, and it is the commonest cause of central line infections in the West. Believe me, this is Western data. And the average number of cases per 100,000 persons in the US is 7, which is certainly not insignificant. If you look at India, we are just behind the US. Other countries have an even bigger case burden. We always consider Candida as a late onset hospital-acquired infection. after several days in the ICU. But that's not necessarily true. I'll show you some data. And we have to start thinking about Candida as an infection control hazard. It's not just in that patient, stays to that patient. It's like a multi-drug resistant bacterium, as we'll see with Candida auris. Now, Candida kills you. It's important to know this. There is the classical study showed 39%, but the biggest Indian study says that just because of this infection, you are at least, you're likely to lose at least 1/5 of your patients. There is a recent study in the echinocandin era, which is important because this is what we largely use, still pretty high. So about a quarter of these patients die due to the disease, not due to the underlying illness. So this is due to the infection per se. Now, this is probably the most important part of my slide in my presentation. You need to know who gets Candida. And if you're losing focus at the end of a hard day, just remember these two things. You need to have a central line, and you need to be on broad spectrum antibiotics that wipe out your endogenous flora. All these other risk factors on the right side of your slide are also risk factors, but perhaps less important. So certainly TPN, diabetes, steroids, dialysis patients, neonates, abdominal surgery, these are all secondary risk factors for Candida. The recent Surviving Sepsis campaign, which our intensivists would be well familiar with, went and actually detailed all these risk factors for Candida sepsis. Surrogate markers such as beta-D-glucan will be heard about subsequently this evening, gastrointestinal perforations, etc., etc. But the number 1 and 2 are you need to have a central line and you need to be on broad spectrum antibiotics. That is when your antenna for invasive candidiasis goes up. Now, there are two types of invasive candidiasis. They are the easy ones, the ones in whom the blood culture flags, just like our patient, makes our job easy. They may or may not have tissue in organ involvement. But then there are the cases which actually invade tissue, classically in the abdomen, without a positive blood culture. They're a little more difficult to diagnose because you don't have blood culture data to aid you. And this nice pictorial kind of tells you that there is an overlap. You can have both positive blood cultures and deep-seated candidiasis interlapping with each other, just each alone. And if you use some of these modern modalities of diagnosis, such as biomarkers, etc., then you can actually increase the number of cases you pick up in each category, which will be discussed a little later. Especially intra-abdominal candidiasis, this is notoriously difficult to diagnose. You have to have a high index of suspicion. It can be seen in up to 40% of patients who undergo repeated GI surgeries. Classically, it's an upper duodenal perforation. Interestingly enough, upper GI perforations carry higher risk for Candida compared to lower GI perforations, anastomotic leaks, acute necrotizing pancreatitis, especially when they get necrosectomies. Blood cultures are often negative, and often you will need surrogate markers like a beta-D-glucan, which we'll discuss later, or by the presence of cultures from intra-abdominal specimens. Now, this is an important slide as well, because this tells you why you can't just wait. When you think of Candida, when the thought of Candida goes through your mind in a critically ill patient, you probably need to intervene, because if you intervene early, this patient's mortality is about 15%. On the other hand, if you wait for your blood cultures to flag, the mortality has gone up to 40%. So this kind of data tells you that if you're seeing a sick patient and there is a possibility of Candida, you shoot first, think later, draw your cultures, start your antifungals, and then sort it out later based upon what things turn out based on your tests. And that is why we have this maxim. When you think of Candida, start covering it. Especially in septic shock, mortality goes from 100% to 50% if you start therapy early. Also true in neonates, which are another high risk factor, high risk substrate for invasive candidiasis. Now, all of you need to brush up your microbiology. Unfortunately, all of us non-microbiologists out there, it's not just enough to know that you're treating Candida. You have to know what that second name, what the species are. The kind of good guys are on the left side of the slide. Candida albicans, tropicalis, parapsilosis, guillermondi. These guys are usually fluconazole sensitive, usually, not always. The bad ones are on the right side, Labrata, Crucii, Hemoluni, and Lusitaniae. I haven't spoken about auris as yet, because that is a really, really bad one. We'll spend some time on that. So you have to ask for the species ID. You have to ask your microbiologist to tell you what the species is. Often just by knowing the species, I know that this is inherently resistant to fluconazole. Now, these are some unusual organisms out there. Note that they keep changing the terminologies here just to confuse us clinicians. But anytime you see some of these unusual names, Lusitania, Killermonda, etc., note that azoles can be resistant. Some of them can even have high MICs to echinocandins. So you have to know a little bit about the species as well, not just the genus in general. Now, this is a little bit of a slide. This is worldwide data. You can see here that worldwide, the commonest Candida is Candida albicans. That is why WHO included Candida albicans, even though it's fairly easy to treat with fluconazole in their problem pathogen list. On the other hand, Indian epidemiology is somewhat different. I'll show you this. This is an Indian study on the right side, which you compare with, say, US study or European data. You will see that our commonest species is Candida tropicalis. Okay, we see the other species too, but tropicalis, that one just loves a tropical country like ours, and this is not just unique to India. Other countries, including Latin America, have a high prevalence of tropicalis as well. This study was kind of important because this came out about 10 years ago from Gangaram Hospital in New Delhi. They use a lot of antifungals. They do a lot of liver transplants. So they have kind of stepped up their antifungal use. Whatever drug you're looking at, they've started, they've used more and more. And you can look at the resistance rates in Candida kind of going up in parallel. So you use more antifungal, perhaps you abuse it a little bit more too, and you end up with more resistance. So often resistance is a function of how much antifungal you are using in a particular hospital. The same study showed that they had this Candida hemuloni, which they found quite a lot. They also had an overall 68% prevalence of resistance, which was quite high. This is our own data from Apollo Hospital, Chennai. You can see that our main species is Candida tropicalis. And you can see here that this is largely fluconazole sensitive, low rates of resistance. On the other hand, we had many of these other species as well, some of which, say, hemuloni, were 100% resistant. So I would encourage all of you to get your microbiologist to provide you this kind of data in your hospital. What are you seeing in your hospital? What percentage of your isolates is fluconazole resistant? Because that will determine everything from empiric therapy to definitive therapy. Now, if you don't have that kind of data available in your hospital, then you have to look at the biggest Indian study of all on the epidemiology of invasive candidiasis. This is by the FISF, Dr. Chakravarti's group. Many microbiologists are part of this study as well. And this looked at 1,400 patients. So it's really generalizable to most parts of India. Patients who are not that sick, even lower Apache scores, developed Candida, and not so late. The mean time to candidemia was about a week after admission. About 20% of all these patients died due to their Candida, not just due to the underlying disease, which was crude mortality was even higher. Tropicalis was the commonest, followed by these other species, a little bit of Glabrata and Hemuloni as well. Public sector hospitals had more of the relatively resistant Candida auris. And overall, azole resistance in about 12%. So about 88% of species would be sensitive to fluconazole. And luckily, at this point, at least in 2015, all isolates, almost all isolates were echinocandin sensitive. So this is the biggest data we have available. However, it's always useful to study what is going on in the West because, it's a matter of time before epidemiology changes, probably in this direction. They are seeing a lot of Candida in neonate. They are seeing second episodes of Candida. They can often see more than one species. And in the US, echinocandin resistance is emerging. They started using a lot of echinocandins because they were having an increasing problem with Candida glabrata. And you can see here that resistance rates are creeping up, echinocandin resistance rates more than 10% in some centers. And they have this particular mutation in the FKS1 and FKS2 gene associated with echinocandin resistance. And clearly, the biggest risk factor for echinocandin resistance was echinocandin exposure. So factor in what antifungal your patient has received. And often you can predict what the likely resistance in the next candidemia episode is going to be. Now, Candida auris is a very, very important worldwide pathogen. As I told you, it's on the WHO list. It kind of came into the news in 2016, simultaneously emerged in 4 different continents. Don't ask me how it did that, but it did that. And often it is disseminated within countries of a single clone. There are many hospital outbreaks described due to this Candida species. Remember, this is a bit tough to identify for the average microbiology lab. I'm sure Dr. Umabala would speak more about that. All of them have high MICs to fluconazole. Many of them have resistance to echinocandin as well, and some of them are resistant to everything. And look at the mortality rate. Sometimes because they're so difficult to treat, or you pick up the diagnosis late, mortality can reach 70%. This stuff just hangs around in hospitals for long periods of time. It kind of desiccates, dries out, survives all over the ICU. If you have one case, it's a matter of time before your entire ICU is infected, unless you follow very stringent infection control measures, the kind that you would institute for, say, a carbapenem resistant organism. So this is intrinsically hardy and resistant to many types of disinfection. The biggest study on Candida auris candidemia, the Indian study, was published by Dr. Shiva Prakash and his group. 1,400 patients, 74 patients were due to C. auris out of these. And when they looked at this, they found that this was higher somewhat in public sector hospitals. Well, my hospital sees a lot of Candida auris, and I'm not in the public sector, so you can't really say that. Note that there was a lot of resistance. Fluconazole, very, very lots, high rates of resistance. Even echinocandin, there was some resistance. So this is intrinsically a resistant species. So if you ask me as a clinician, when would I suspect Candida auris? I would say prior antifungal exposure, especially fluconazole exposure. The sicker your patient, could this be Candida auris? A late onset candidemia, because earlier episodes may be due to more sensitive Candida species. If your hospital is ever seeing C. auris, please think of C. auris in your patient. There are certain laboratory flags. If your lab is identifying these species, then please think, could this be Candida auris? You may need to do other techniques such as MALDI-TOF to identify it definitively. And I'm sure these microbiologic aspects would be highlighted. So if you have MALDI in your unit with an updated database, usually you would be able to identify it correctly. Now, the COVID outbreak did not do any good to Candida. This is a very busy slide just to tell you that we had a huge spate in candidemia after COVID came out. The incidence was pretty high. C. auris was an issue. This is the study from New Delhi, India, which showed a lot of Candida auris in COVID patients. This is another study from Northwest India, which showed a 2-fold increase in the incidence of candidemia in COVID-19 versus non-COVID-19 patients. And Candida auris was the commonest. Azole resistance was quite common as well. And why do you think this happened? Well, COVID patients get immunosuppressants, steroids, other immunomodulators. They stay in the ICU for long periods of time. They get antibiotics, but perhaps most important was poor adherence to IC protocols. We were more worried about protecting ourselves with our PPE, and we were more worried about kind of bed turnover because we were kind of swamped with these patients. That might have been a reason why there was so much candidemia then. There are some other species with very curious names. Remember that Candida auris is not the only one. It certainly is the biggest one, but not the only other one out there. Now, this is just a paper on 7 cases of Saccharomyces, which we published. Remember, Saccharomyces is there in that probiotic capsules, which are often given to patients. So if you have a central line, if you have a vulnerable neonate, please avoid these probiotics because they will get into the patient's blood, not just into the patient's intestine. So this is my last slide in the epidemiology section. Suspect invasive candidiasis in febrile ICU patients with central lines who are on broad spectrum antibiotics. Candida auris is the commonest species in India. but the most dangerous one is Candida auris, which is multi-drug resistant. It's easily misidentified. So please talk to your lab closely how they are identifying this. And it's very transmissible, big infection control hazard. And there is a lot of candidemia in sick COVID patients. Thankfully, we are not seeing much COVID at this point in time. Thank you very much. I will stop here and I will stop sharing slides, and I'll be happy to take any questions if there are. Over to the moderators.
Dr. Ram Gopal Krishnan, you would all agree, you got a gist of the epidemiology and how the epidemiology is changing, particularly to candidiasis. So he's briefly, in a nutshell, he's listed out the species of various candidiasis species, what are predominantly seen in the Western population compared to what we commonly see here in India, tropicalis. But importantly, he also stressed on, a new species of candidiasis, which is emerging, the role of echinocandin resistance, which is now taking quite a major, they're facing a huge issue in the Western population and so forth. So I'll be happy to take some questions if we have, because, sir, I think sir has requested that he's got some commitment and he would like to exit after this. So you can unmute yourself and put your question to sir. Looks like you were.
Dr. Nawal, I have a question for sir.
Yes, sir.
First of all, an excellent presentation, Dr. Subramaniam. Just wanted to ask you, you mentioned that sometimes very difficult to identify candidemia in a GI issue. So how about, how do we really suspect in cases if somebody really has candidemia? Because to start empirical antifungals, as you said, fluconazole is something that may be resistant. To start something empirically without really having a documentation may be a little difficult, especially in the private sector. So I'd like your opinion or your
So the issue is, how do we diagnose intra-abdominal candidiasis? The first thing there is to suspect who's the host who develops this issue. Somebody with recurrent pancreatitis who's had necrosectomies, somebody who's had repeated bowel surgeries, say open bowel or burst abdomen, whatever the reason, somebody who's perforated upper GI perforation, surgery went bad, repeated surgeries, etc. That is the host. Now, if that host develops a sepsis syndrome, then the thought of Candida should cross your mind. Obviously, the differential diagnosis is bacterial peritonitis versus other causes of ICU fever versus invasive candidiasis. So that is the time when your blood cultures may or may not pick up. Often, as I said, it is not a central line related. It is due to the GI problem that the patient has peritonitis. So if you have a freshly inserted drain or your patient has freshly gone to the theater, please send samples for culture. Routine cultures will grow Candida if they are there. The serum beta-D-glucan is a very good biomarker which tells you that you may be dealing with invasive candidiasis. Unfortunately, a lot of other things can cause a false positive BDG. For instance, exposure to surgical gauze or albumin or IVIG or sometimes dialysis membranes can cause a high beta-D-glucan. On the other hand, a negative beta-glucan kind of rules out the disease almost with 100% negative predictive value. So a negative test, negative beta-D-glucan, negative blood cultures makes your diagnosis highly unlikely. I hope that answered your question.
Yeah, thank you. And anybody on a chronic Foley's catheter, would that also be a trigger factor for a possible Candida?
Yes, Candida can certainly get in through the urinary tract. However, candiduria on its own usually is a local syndrome. All you need to do is to remove the Foley catheter. However, the patient with candiduria and a febrile syndrome, please think of invasive candidiasis. But certainly, the three main sources of Candida in the ICU are the central line, the gut, related to gut surgeries, etc., and the urinary catheter.
Thank you. Thanks.
Sir, I have a question, sir.
Yes.
So this is Dr. Anand Bokre. Very excellent talk, sir. When to stop systemic antifungal drugs, especially in a epidermal dermal cases, sir.
So the answer in terms of candidemia, if your blood culture grows candida, it's quite easy. You stop it 2 weeks after the first negative culture. So on day 0, if your blood culture grows, 48 hours later, you repeat a culture. If that is negative after 48 hours of therapy, from that day onwards, 14 days of therapy. If your blood cultures don't grow and you're suspecting invasive or tissue candidiasis without candidemia, then there's no hard and fixed answer. Typically, we give 14 days of antifungal therapy. We try to avoid expensive drugs like echinocandins. If the patient is improving, we would de-escalate to something like fluconazole, which could even be given orally. Remember, the systemic dose of at least 6 mg per kg, so at least 400 mg per day.
Thank you.
Yeah, I think for the questions, I thank Dr. Ram Gopal Krishnan for his very lucid presentation. And we'll now move on to the second speaker in this CME series. And I wish to introduce Dr. Uma Bala. She's the professor and head Department of Microbiology and very instrumental in starting this series on behalf of the ICMR Advanced Mycology and Diagnostic Research Center here at NIMS. And she's passionate about mycology. And she's basically going to give us an overview of the laboratory diagnosis of invasive candidiasis. So do we have Dr. Uma there?
Yes, sir.
Good evening, ma'am. You can share your presentation and start.
Can you see my presentation?
Yes, ma'am.
Good evening to all, and I'm very thankful to IMA and also API for allowing me to co-host this program, and I'm very thankful for the audience who have been very such a huge audience I have because for this particular seminar, because my whole intention on behalf of the MDRC is that we talk more about fungal infections. I'm very thankful for this beginning, which have given me the opportunity to participate and hold this webinar along with you all. Yeah, so my topic today is laboratory diagnosis of invasive candidiasis. So has given a wonderful introduction to the disease. So I would be really talking about what are the diagnostic modalities available. We all know that invasive candidiasis. Why did we choose invasive candidiasis as the first topic? That's because 70 to 90% of the invasive mycosis we encounter are invasive candidiasis. So that forms a major chunk of the fungal infections we deal with. And when we talk about invasive candidiasis, so has already mentioned. So we have candidemia, we have deep-seated candidiasis, and we have a combination of both. And it's associated with very high morbidity and mortality, as already mentioned, and prompt and accurate diagnosis. A very early diagnosis is so essential, and also the diagnosis should be very sensitive and specific. The method which we are using should be sensitive and also specific, so that we don't end up using unnecessary antifungals. So that prompt and accurate diagnosis is essential so that we can start the therapy earlier, and most importantly, to avoid unnecessary use of antifungal agents, especially with the rapid emergence of Candida auris, which sir mentioned. It's quite a difficult pathogen to deal with, and we are seeing more and more cases of Candida auris because of inappropriate antifungal use across the country and across the globe for that matter. So when we talk about diagnostic modalities, we all know about the culture methods for fungi, that those have been the age-old methods which we have been employing, and we also have the non-culture based detection now. So when we the most important and the gold standard for diagnosis of invasive candidiasis is obviously the fungal culture, mainly the blood culture, because the patients who develop these invasive candidiasis, they have multiple risk factors, and it may not be always possible for us to do a tissue diagnosis and take from a deep-seated candidiasis, do a biopsy and do the diagnosis. It's very difficult. So the commonest method which we use for diagnosis of invasive candidiasis is the fungal blood culture. And now The fungal blood culture, because of its low sensitivity across the spectrum of candidiasis, invasive candidiasis, and also the longer turnaround time. When we do a fungal culture, it almost takes around 3 to 5 days to get a final report of the Candida organism, the species, and if we do the sensitivity, also that it almost takes around 3 to 5 days. So the turnaround time is quite long, and the patient's condition may not really allow us to have such a huge turnaround time. So now there are so many methods which are coming up with varied sensitivity, specificity, NPV and PPV, like the pathogen-derived biomarker detection test. That is, we either detect the fungal DNA, the Candida DNA by PCR, different methods of PCR, conventional, RT-PCR, nested, etc., or we detect the fungal antigens, that is, which are there on the cell wall of the fungus, like mannan and beta-glucan. And then also, we can also detect the human response to the fungal antigen, like we have the anti-mannan antibodies, which are antibodies which are developed towards the mannan antigen of the Candida. And now there are very promising tests being coming up into the market, and already some have come, and mostly in the future we'll have the other tests also. So we have PNA fish, which was tried, but more than that, a very promising test now, which has been already is started using, is the T2 magnetic resonance imaging. And hopefully with the cost coming down in the future, we may have these tests also quite near in the near future. And of course, MALDI-TOF. That's one of the breakthroughs in diagnostics has been MALDI-TOF, and compared to the molecular methods is extremely cheap, and the turnaround time is very less. And it is something, though the initial costs of establishment are very high, it's a very, very useful test across the all specialties of microbiology, whether it is bacteriology, mycology, microbacteriology. So let us just deal with these tests one by one. So what do we really want in an ideal diagnostic test for candidiasis? It has to be minimally invasive, mostly a blood test rather than a biopsy or something. Ideally should require low volume samples. The turnaround time should be low. It should require minimal labor, minimal technical expertise, so that we can do it in every place. And also it should fit within the normal flow of activities in the laboratory. And it should be very sensitive, very specific, and also provide the speciation and antifungal susceptibility data, because all Candida are not the same. As sir mentioned, there are so many species with varying sensitivity, and you have to also do the antifungal susceptibility for all these organisms. And also this test should have multiplus capabilities, and most important in our country is the cost effectiveness. So what should be our testing goals? For any test for invasive candidiasis, we should be able to identify patients early in the course of invasive candidiasis. As we all know, the mortality keeps increasing exponentially with the delays, and identify patients with candidemia who have deep-seated candidiasis, identify patients with candidemia who are likely to develop deep-seated candidiasis, and identify patients with deep-seated candidiasis but negative blood cultures, and also preferably provide prognostic information. By the test, we may be able to predict what should be the outcome or what is the probability the patient will go into complications. So these are all the ideal goals of our blood test, of the tests for available. Now, blood cultures, the first test, none of the tests which we have really satisfy all the criteria. If you take the blood cultures, that is the gold standard. We can never do away with blood cultures for diagnosis of invasive candidiasis. In spite of all the new tests coming up, we have to realize that blood cultures, and along with that, the new tests also supplement these blood cultures as the diagnostic modalities, and blood cultures can never be replaced, because this is the only way where you can isolate the organism, you can identify, and you can do some phenotypic tests like the antifungal susceptibility testing. And if you have multiple pathogens in a single blood culture, that also mostly will be identified in blood cultures when you do a culture. And this cannot be replaced by non-culture tests. Only the non-culture tests can be added up to these two for early diagnosis and more sensitive and specific diagnosis. But as I said, the disadvantage is a long turnaround time, because what we do generally is blood cultures. When the blood bottle flags positive, we do a gram smear, immediately inform the smear report to the clinician, whether it's an yeast or a gram-negative bacilli or whatever, and then we put it on a culture plate, conventional plates which you all have seen, and then it takes another 24 hours to grow, and we take further 24 hours to put it in identification systems, whatever we use. In NIMS, we use Vitek2, so we identify the species by these systems. So Basically, the longer turnaround time is a major drawback. And what has been found was, if we take invasive candidiasis as a whole, the sensitivity is not more than 50%. And also, there's a problem of contamination. Blood cultures do get contaminated. We see here the whole three areas of overlapping areas of invasive candidiasis. And if we talk about the blood culture sensitivity, is very good in the candidemia, where the organism is there in the blood. When you have candidemia, deep-seated infections, and along with candidemia, if we do the test after the candidemia has cleared, the sensitivity becomes quite average. And if we take, if you look at deep-seated candidiasis without candidemia, obviously the test will be negative. So, and what is important about the blood cultures for detection of invasive candidiasis? The type of culture system which we're using, and preferably all over the world, the ideal methods are the continuous monitoring blood culture systems, and the most commonly used are the BacT/ALERT and the BacTIC, and they continuously monitor the bottle. And definitely the turnaround time, the positivity, the time to positivity is very low compared to the conventional culture methods which we're using all these days. So it's very important to have an automated system compared to a conventional system. And then again, the same processing is the same, just like the other conventional cultures. And then what are the things which determine our blood culture positivity? Why is the culture positivity so low in most of the studies? One of the reasons could be because the optimum volume of blood is not collected, the number of sets are not collected. And most of the times when we see in many of the hospitals, blood culture means only one single bottle. It is as good as not doing it, actually. So we need to understand that the volume of blood is very, very essential, and the recommended volume is at least 30 to 40 ml of blood to be cultured in 24 hours. We have to keep that in mind, otherwise the sensitivity will be very, very low. And if you really follow the optimum blood culture volumes and the sets, we should be able to get good sensitivity with even this blood culture. And this is in the pediatrics. We will again do that in a separate session, because that's a complete different game altogether. And that depends on the body weight of the children, how much we collect. And all these automated systems have media which contain antibiotic and antifungal binding resins. So when the patient is on treatment, basically it neutralizes those and improves the isolation. And another important thing which affects the blood culture results are the transport. There should not be any delay in transport. The bottle should not be refrigerated. And one of the most important thing is collection, aseptic collection of the culture. Otherwise, we end up having all sorts of organisms, and we unnecessarily treat the patient because there is some growth of some skin commensal, which we are not able to clearly make out whether it's a skin contaminant or a pathogen. And ideally, it should be collection by direct venipuncture, but often it doesn't work out in the ICU because patients have mostly are on central lines, and it happens that we need to collect because there's no other way. So coming to the non-culture based methods, we all know these non-culture based methods, either we are detecting the DNA of the organism or we are detecting the antigens of the candida. So this is the cell wall of the candida. We can see the beta-D glucans, the manoproteins, that is the mannans, which are there in the cell wall. These are the proteins which are abundantly present. And so many antigens and antibodies have been tried for detection of diagnosis of candidemia. Yes, diagnosis of candidemia. But the ones which are commonly used are the mannan and anti-mannan antigens and antibodies, the mannan antigen and antibody. And the problem with the mannan antigen is the concentration may be low and it can be rapidly cleared from the body. And also for the antibody assays, when we look at the antibody assays, if the patient is immunocompromised, the sensitivity may be decreased, the time to needed to mount an antibody response may be high. So all these also may affect the results. But what has been seen was a combined mannan anti-mannan antibody assay has the best performance instead of doing it alone. Both the tests, if they are combined, they have a reasonable sensitivity and specificity for screening for candidemia in the intensive care. But the antigen sensitivity specificity differs on the species also. Candida albicans, it is very good, but slowly it decreases. It's more than glabrata and tropicalis. Among the three, it has the lowest sensitivity of the test has the lowest sensitivity for this particular species. And when we talk about Mannan, anti-Mannan, somebody was asking about the deep-seated candidiasis, like, intra-abdominal candidiasis or hepatosplenic candidiasis. It has been seen that these could be an answer when our blood cultures are negative. It's not only the test becomes positive earlier, and there have been studies where they've seen that 73% of the patients had one test positive almost 7 days before the blood cultures became positive. And also in hepatosplenic candidiasis, even before the radiographic changes, almost 2 weeks before the radiographic changes appeared, the test was positive. So that has a very good value. And now another test which is being used in most of the referral laboratories is the beta-D-glucan. It has a lot of issues, false positivities, a few false negativities, but still it has a lot of value in early detection of candidemia. What are approved? The Fungital assay is approved by the FDA. There are other tests like VACO, BDG, Glucatel, Dynamica, which are available. But what we need to remember with a crucial point in beta-D-glucan, it is not a test only for candidiasis. It is a test for all invasive fungal infections apart from Cryptococcus, zygomycetes, and blasto. So those are the 3 organisms which do not give positive results with BDG because the wall doesn't have the BDG. But all the other, any other invasive fungal infections along with candidiasis can be detected. And they have done studies comparing 2 different methods, the VACO and the Fungital, and the results are almost comparable. This assay basically is a different sort of mechanism. It's just not a normal ELISA. What we detect here is the factor G, which is activated by the BDG in the patient sample, and it sets in a coagulation cascade, and that is how the assay works for detection of the BDG in the patient sample. But the test is very laborious, a lot of false positives, and when the sample is sent to a reference lab, the short turnaround time has no value because ultimately by the time the test comes back, it becomes very late. But one improvement has been that now the Fungital stat has come up, which is just 7 tests at the same time, and you can do it the same day, and the values are almost comparable with the Fungital assay. So this test is promising in the sense you can do it the same day. You don't need to do batch testing, unlike in the assay. And the sensitivity of specificity in the recent Cochrane database review, the sensitivity has been found to be 81.3% and the specificity around 64.1%. And always better to repeat the test. And if 2 consecutive tests are positive, it is more specific. And this test has more value as a test to rule out invasive fungal infection rather than a test to rule in. So the negative predictive value is very good. And again, the species also matters. The sensitivity of this assay is diminished for certain species like parapsilosis. And yes, there have been several comparisons, and they have seen that BDG, PCR, and culture, you can see the result. The sensitivity at one point, the culture sensitivity was only 17% was BDG. In 62%, it was positive, whereas PCR was 88% positivity in case of a candidemia. And so a combination of this BDG and PCR could be a good strategy for early diagnosis of invasive candidiasis. And the most important thing about BDG is the huge number of false positive reactions. We can have false positive in a patient who is undergoing dialysis because of the cellulose membranes which are used. So it may give you false positive in the ICU in patients who are undergoing dialysis, CRRT, etc. Patients who are receiving albumins, IV immunoglobulins, patients with cellulose dressings, and patients on several antibiotics, and most important, some of the bacterial infections which have endotoxemia, and that endotoxin can trigger a factor C, which can also initiate a same reaction as the BDG. So you can have positivity even in blood cultures, even in bacterial infections. So you have to deal with all these false positivities, and you know that it is negative for some fungi. So we need to consider all these factors and then use this test. And coming to the PCR-based assays, PCR basically detects the DNA. We have so many in-house methods and commercial methods available. But these have a lot of varying sensitivity and specificity, and each time the reproducibility is not very good, but the methodologic standardization, multi-center validation have not been really been very uniform with these PCR methods. But there are other methods which are now coming up, as I said, the novel methods which are very promising, the MALDI-TOF. And among these, I would mention the MALDI-TOF and the T2 magnetic resonance imaging, which are really promising. MALDI-TOF assay, you have it available in India, and hopefully we are getting it in a few months. The Bruker MALDI-TOF, and it's also available with Bimuro. 2 systems are available. And here, basically, you're looking at the protein profile of the organism. And this has been used not only for direct detection of the organism, the identification of the organism which has grown in the blood culture in a normal blood culture bottle. When you isolate the organism, you can use it to identify the species. And as Sir was mentioning, we had lots of problems with the Candida auris identification in the commercial identification systems, which now have been updated. But Candida auris is a very difficult organism to identify in the laboratory, and now things are improving. But Malditov gives an excellent identification of most of the Candida species. So once you have grown the blood culture, you can identify the species by taking the blood culture broth. So you basically decrease the turnaround time by almost around 48 hours. You don't have to wait for the culture to grow. You can directly detect it from the blood culture broth, and also you can identify the grown isolates to the species level, and it identifies almost all the rare species of Candida. So, but the limitations, high setup cost, a very good database should be there. It should be developed involving all the, encasing all the fungi. And the test sensitivity is not that good when you talk about whole blood samples. It's still not being used for detection from whole blood samples. Only when the blood culture is positive, you can use it. And so there have been several studies in India from Chandigarh where they have tried to identify. So these are all the spectrum of species which they have identified using the MALDI. And most of the 98.9% of the PCR sequenced yeasts were correctly identified by MALDI. So it is very, very promising. And this again is the recent study in 2020 which they have published. They have done directly from the blood culture, flagged the bottle, they have done the identification and done the broth microdilation, direct susceptibility with a Vitek. And it has been very good. The results are very good with this. And this test is, I would end with this test, the T2 magnetic resonance imaging. Till now, we really don't have very good tests for direct detection of the Candida from the blood sample. So many PCRs have been tried, but there are a lot of problems with the PCR because the load of the organism is very less. And the most important, the fungal cell wall is very difficult to lyse, and to extract the DNA is a very big problem. And so the extraction is varies according across the different tests. So, but T2 magnetic resonance imaging is one test which has been found to be very good sensitivity, around 88 to 100% sensitivity, and a very good specificity of around 97.8 to 99%. This is a very simple instrument to use. It detects the 5 most common species. The spectra is being increased for detection, and hopefully the cost will come down, and we will be surely getting this instrument in India sooner, because as for all the equipment, slowly once people start using it, the costs do come down. So we are hoping that this equipment comes out, and this will really help us in early identification of Candida directly from the blood sample. So that would be a great help. So just to summarize the potential advantages and disadvantages of culture and non-culture based test. For the culture based test, we don't really, we have the organism in hand, but the turnaround time is not really good. And sometimes we can have multiple organisms coming in, and that also will grow in the culture test. But the main drawback is the turnaround time and the time which takes to ultimately give the final report, and it may not be clinically useful to the patient. And for the non-culture based test, basically we have seen here the advantages: very rapid turnaround time, and it doesn't depend on the viability of the organism. Whether the organism is dead or alive, it can detect, and it will become positive prior to cultures if it's well standardized. And also multiple targets can be detected. And but the disadvantages are that you don't have a culture to do the sensitivity testing, which is very, very essential in the laboratory diagnosis, and it cannot maybe speciate Candida, all the Candida. So that's a problem when we just get a Candida positive. We don't really know the species when we do a beta-D-glucan or this one. And sometimes some of the species, the sensitivity is better, while some the sensitivity is low. And most of these non-culture based tests have a very good negative predictive value. And because of the false positivity, the PPV may be very less. So thank you. So blood culture remaining the gold standard. Non-culture tests have to be interpreted judicially to identify patients with invasive candidiasis, knowing all the false positives and the false negatives. And we have to understand the sensitivity, specificity, the pre-test probability of a fungal infection before we order a test. One of the promising tests is the T2MR, and cost-effective patient management strategies have to be worked out with culture and non-culture tests, a combination of all these tests along with our clinical judgment. Thank you. And I would just want to share with you that Now, NIMS has been recognized for establishment of the ICMR Advanced Mycology Diagnostic and Research Center. We're just beginning, and we are getting all the whole array of tests, hopefully in the near future. So any query about anything, you can always contact me. And thank you all.
Thank you. Thank you, Dr. Uma, ma'am. As usual, a very lucid overview on the diagnostics of this particular candidiasis. So, ma'am has over the last few minutes given us a gist of how important the blood cultures are, the mechanism, the way you have to collect the cultures, how much of blood is required to get a good analysis of the fungal infection, and also listed out a whole array of other non-culture related new modalities which have now come in. And also I was quite impressed with something like a T2MR, which shows such a high sensitivity. So that's a new learning for all of us. So, I mean, I'm sure there are a few questions here, ma'am, before we go on to the next speaker. So we have 3 or 4 questions which have been listed out. I'd just like to take a couple of them. Yeah, 1 minute, ma'am. Yeah, so the first question is from Dr. Ravi Teja. He was asking about BDG negative. In which fungal infections do you get?
Yes, sir. The BDG negative is in cryptococcosis, and then you have this zygomycosis and also blastomycosis. Blastomycosis, of course, is not a problem here. Of course, we can't say there are imported cases, but mainly cryptococcosis and zygomycosis or mucormycosis now called, you don't expect BDG to be positive because the BDG levels are, BDG is not really there sufficient amounts in the cell wall of these fungi.
Right. Dr. Harsha has asked you this on the same lines. How is T2 sequencing testing helping in this particular area?
Which one?
The T2 sequence.
T2MR. T2MR.
Yes.
Yeah. T2MR, basically, when we do a conventional PCR, the sensitivity is very low because the DNA extraction, they're highly varied and each test has a different extraction method and it is not reproducible and all that. And so that's why all these years, in spite of having so many, studies being conducted, not a single test has been really found to be the gold standard for PCR. Basically, PCR method has not been really validated uniformly. There are so many commercial methods available, but the importance about T2MR is that all these other tests, whether it is MALDI, everything, till now we have basically detected the organism after the blood culture has come positive. That is, we have inoculated the blood into the conventional blood culture bottles or the automated culture bottles. Once it comes positive, from there we are identifying it and we are decreasing the, of course, the turnaround time by almost 48 hours. Yes, but this is the only test which shows very promising sensitivity and specificity for the detection of the organism Canada directly from the blood sample. So you can just take a blood sample and directly detect it. And that's a very, very unique technology which they use.
So another question from Dr. Ravi Teja. Can MALDI give sensitivities?
MALDI?
Give sensitivities.
In direct detection?
Yes.
So MALDI, now they have tried, like, now they are trying to standardize it for direct detection, but till now it's not like, completely validated. They are trying that. In fact, MALDI is not only being used for identification of the culture isolates once they have grown. It could be blood culture or any culture isolates, whether it is mold or yeast. It has been found to be an extremely good method and very, very least expensive compared to molecular methods. And also identification from the blood culture broth once the bottle is positive. But directly, and also even they have even detected the antifungal resistance genes also from the blood culture broth. But till now, the direct detection from the blood sample with MALDI is still not really standardized. People are trying.
I think the last question, polyfungal infection growth, which is dominant, how to make out?
Yeah, I can understand. Which one?
Polyfungal infection growth.
Yeah.
Which is dominant, how to make out?
So you have to give me an example, because first of all, if you are growing multiple fungi, first I would look at the sample collection. First of all, is it really truly positive? Is it truly a mixed infection, or it could be just a contamination? Because unlike other organisms, fortunately or unfortunately, fungi have a lot of trouble when it comes to cultures, because they are there everywhere in the environment. So the first thing we have to rule out when we get multiple fungi is the fact that is it a contaminant? And how will that help? We have to look at the direct examination. Direct smear is extremely important for mycology. I'm not talking about blood cultures, we can't really detect, but in case of other tissues, sinus, pus and all that, sinus tissue and all, if we find the organism in the direct tissue, that there is a, suppose I say there is an yeast and there is a, in a sterile tissue, there is an yeast and you have a mold growing both together in a sterile tissue, then I can say, yes, it is a mixed infection. But I have to look at the direct examination before I conclude about the culture. And culture, if you are growing multiple cultures in the same non-sterile sample, we have to be very cautious, repeat it, and also look at the direct examination again to see whether it's truly a mixed infection or just a contaminant. And if it comes to yeast, if you're talking about Canada, definitely when you look at Canada, 2-3 species of Canada growing from a properly collected blood sample, both of them are significant. There is nothing like one is predominant and the other is not. There can be mixed infections, especially because central line colonization is one of the commonest risk factors. You can have 2-3 species of Canada, colonizing, but you need to still repeat and confirm the.
You would agree, it was a very lucid, and there'll be a lot of questions ahead. And I thank Dr. Uma for a very lucid presentation again on the investigation modalities. We would now thank you, ma'am, for your presentation. We kindly stop sharing your presentation so that we can now request the third speaker of the evening, and that is Dr. D. Padmaja, ma'am. She's a professor of the Department of Anesthesiology and Intensive Care at NIMS, and she's going to give us an overview of what the clinical scores for the prediction of invasive candidiasis are in critically ill patients especially, and initiation of this antifungal therapy empirically. So I request Dr. Padmaja, ma'am, if you can start sharing your presentation, and then we will.
Thank you, Dr. Naval, and I would like to thank Uma and her team, and also IMA and API for giving me this opportunity here. Uma, I think you'll need to stop sharing your screen.
Yeah, I have done it. I was just searching for it.
Yeah.
Okay, so I hope my screen is visible now. Yeah.
Yes.
So if you look at the ICU, I think from the beginning of this program, we have been listening to all the risk factors and for the invasive fungal infections. And from that, we can understand that probably all the recipe that is required for an invasive fungal infection is there in the ICU. So we've got patients who are on broad spectrum antibiotics. Most of them are on that. They may be on steroids. And then there were several conditions which could cause an immune paralysis. So invasive fungal infection is possible or is very high in intensive care units. So if you look at the pathophysiology, it is either because of the increased colonization density. So that is usually triggered by the broad spectrum antibiotics. And there's also a breach in the barrier defenses, like the skin mucosa and the gut barriers. We've been listening that the intestinal surgeries are higher risk, and whenever there is a pancreatitis, that is also a higher risk. And there are also like a lot of invasive lines that are placed in the ICU that could increase the risk. So in the host factors, we have several comorbidities, and the patients may be on chemotherapy or other immunosuppressive drugs. So if I have to just put this figuratively, yeah, you can see that enhanced colonization because of the mucocutaneous surfaces. And then we have treatment because of the invasive procedures, especially central venous lines, the PD lines, and also hemodialysis in the ICU. And immunosuppression because of various factors, either because of the host factors or because of the interventions in the ICU. Can cause immunosuppression and increase the risk. And also there are also several other risk factors, like the sicker patients with an Apache score of more than 20, patients with burns or severe trauma with an ISS score of more than 20, especially patients receiving TPN with high lipids are at a higher risk. And if they've had a recent surgery, especially abdominal surgery, they can have a risk for fungal infection. Now with all these risk factors, we can see that in the intensive care unit, this is one of the large study that was done, the EPIC study, which is a multinational and a multi-organism surgery. They have looked at the prevalence of the fungal infections in the intensive care unit, and it was as high as 7 per 1,000. But then the length of stay in the ICU significantly goes up when a patient has a fungal infection, as so as does the mortality. And they've seen that the Candida albicans species was one of the most common species in the ICUs. Now, we understand that there is a high risk, but then what are the barriers, or why can't we start the therapy early? So what are the things that probably stop us from jumping and starting an antifungal in these patients? One, we do not have proper evidence that this is a fungal infection. A lot of times patients have fevers that are not unrelenting, not responding to antibiotics, and then you would think, is this a fungal infection? But then jumping and starting a antifungal is still something that we would be wary of. The reasons for this is the culture-based studies, as Dr. Uma was takes more than a couple of days to get a organism and also have a sensitivity to that. And the non-culture-based surgeries, investigations, again, as Dr. Uma said, have a narrow specificity and sensitivity. So relying on them for starting an antifungal is difficult. And we do have advanced techniques, maybe in some specialized institutions, but then not every institution is fortunate enough to have these. And other barriers are the cost and also the need for a skilled person. Not every center even is capable of moving on to these advanced diagnostics. So this is where is the difficulty or the dilemma that is there for most of the intensivists, whether or not to start an antifungal therapy. So if you want to start an antifungal therapy only after the confirmation, we know that it takes time, so it is not early, especially if the patient is on septic shock, it's a big dilemma. And then if you want to start before the confirmation, obviously you would be ending up starting antifungal for most of the patients in the ICU, and then there will be an overprescription of the antifungal. So delaying antifungal, you would be worsening the outcome if the patient really has a fungal infection. And then if you start antifungal for everyone, and the problems with unnecessary treatment. One of the things is that antifungals are not simple drugs. They have a lot of side effects. And also, you would probably pushing most commonly we have heard that the antifungal that chosen is fluconazole, and then you would be pushing the growth towards some non-albicans species. And there's also risk that you would be probably causing a resistant species too. And most importantly, especially in India, it is the cost of the antifungals. If you look at the antimicrobials, one of the most expensive antimicrobials are the antifungals. So we would not like to have an unnecessary treatment in the ICU. But then if you do not want to have an unnecessary treatment, we might be ending up delaying the antifungal treatment. So it has been shown that if the delay is more than 12 hours, the mortality is 10. But if you delay for more than 48 hours, the mortality goes up to more than 30%. And in septic shock, the mortality because of the delay is much higher. So if the delay is more than 24 hours, the mortality goes up to almost 90% in septic shock. So we have to probably have a balance somewhere between not delaying and starting an appropriate therapy. So what are the options that we have in the intensive care? Either we start a preemptive therapy, which is usually based on the non-culture biomarkers, or start an empirical therapy, which is usually triggered by just clinical signs without even waiting for these biomarkers. When we have a patient who is in septic shock and has fever that's not responding to the regular antimicrobials. And then the other option is to have a probabilistic theory, that is, which is based on the scores. And if we are fortunate, we can have a definitive therapy that is based on the isolates. And as Dr. Uma was talking, we are probably going to, in the next couple of probably years, we'll be having more diagnostic tests that would give us the results in as early as 4 hours. So we might be able to be starting a targeted therapy. But then till now, I think we are still going to base on either preemptive therapy or the empirical therapy. So now what is the problem with the preemptive therapy? Now, if we've heard from Uma that these biomarkers have a very low sensitivity and specificity. Most commonly used biomarkers, as Uma said, were the mannan antigen antibody tests or the beta-D glucans. Now, both these tests have a good negative predictive value, but their positive predictive value is less. And and also that predictive value of these tests goes up if we are doing them in a patient who has a high pretest likelihood of FIF. So it is important that we identify patients who require these tests. Otherwise, probably the cost of the test is also very high, and we would be testing unnecessarily, which would increase the cost of the ICU stay. So this is a study that has looked at whether the biomarker-based strategy is helpful in discontinuing these antibiotics. Because the negative predictive value of these tests is high, probably we can base our discontinuation of the antifungals based on these tests. So in one arm, they have looked at the discontinuation of these antifungals based on the biomarkers, and they have found that they were able to discontinue in about 54% of the strategy, as opposed to the routine care, where only 2% of the patients have been discontinued. So this would significantly reduce the cost of the antifungal therapy, but then we would also be worried that if you're not starting an antifungal, you would probably be causing more mortality. But then there was no difference in the mortality between the two groups, and also the length of the ICU stay was also not different between the two groups. So as we understand that mannan antigen lacks the sensitivity, and also it is quite late in the candidemia that you find this positive. So is it so why can't we introduce the antifungal based on these biomarkers? So it has been shown in this study that the Candicept trial, that introducing this antifungal based on the biomarkers resulted in a lesser interval between the diagnosis or potential diagnosis of an fungal infection to the drug. But however, early introduction of an antifungal again did not result in improvement in the mortality. That means that we would be introducing antifungals more often if we went by the markers than if we did not go by them. So because of this, the cost of the antifungal, the ICU cost went up, but then the mortality benefit was not there. So it has been seen that the performance of these biomarkers depends on the pretest probability. So which means that we should be able to identify those patients who are at a higher risk for fungal infections. So in the empirical introduction of antifungals, we would be going more by the clinical parameters. So this is a study that has looked at the empirical introduction of fluconazole in those patients who were hospitalized for more than 96 hours and were receiving broad spectral antibiotic therapy and with a central venous catheter. So with fever. So this is a high risk group, and then they had an empirical fluconazole started off versus the other group where there was a placebo. But then here we expect that this group, because of the high risk, would have a better resolution, but then there was no difference in the resolution of fever between the two groups. So which means to say that the empirical treatment is not really effective unless we choose our patients wisely. Similarly, this is another test study that has shown that when empirical antifungal therapy was introduced, 100 of them in which an empirical antifungal therapy was used did not have a proven fungal infection, whereas only 50. That means in 2/3 of the patients, you would be starting an antifungal unnecessarily. So this brings us to the point as to how to wisely choose our patients as to who would require a antifungal therapy. So if we have some clinical models which would help us to identify these higher risk groups, probably we'd be choosing those who are at higher risk, and then we would be introducing that further. So why should we risk stratify these patients? So one, it would be able to help us to identify those patients who have a higher prevalence of fungal infection, and it will also help us to identify those with a lower risk so that we can stop any empirical antifungal therapy that has been introduced. And then we also see that these diagnostic strategies also work better when we have a patient with a high pretest possibility. So even to choose which patients would require diagnostics to be sent, we can choose based on this scoring systems. So this risk stratification has been done by several authors. So we would go to one of the most earliest risk stratification, that is a clinical prediction rule by Ostrowski et al. So here they have looked at the patients in the ICU to identify those who are at a higher risk of infectious diagnosis, and also so that this will help us to identify those who are not candidates for antifungal therapy. So in this study, there are major risk factors like intravascular devices, recent surgery, broad spectrum antibiotics, immunosuppressive therapy, malignancy, and diabetes. And other risk factors like hyperalimentation with EPN, previous ICU stay, mechanical ventilation, prior candida colonization, concomitant bacterial infection, solid organ transplant, hemodialysis, and HIV. So in this, if there is any one major risk factor and at least two minor risk factors positive, then we would consider them as a high risk candidate for having an invasive candidiasis. So the validation of this clinical prediction rule has shown that it works better and it's good for identification. So that was a very early study in 2003. So a recent study has identified a different risk of a group of risk factors. These include the acute kidney injury, the renal replacement therapy, parenteral nutrition, and multifocal candida colonization as risk factors. And a weighted score was given for each one of these risk factors. And the total score is 13. So the cutoff for diagnosing fungal infection with this score was 5.51. And then it has been shown that this score performs well and has a good sensitivity and specificity. And this is a risk scoring that was done for surgical patients. And they have shown that in patients with female gender, upper gastrointestinal surgery, cardiovascular failure, and use of antibiotics, each one has a weighted score of 1. And in the presence, if there are any 3 qualifiers, the risk of having a peritoneal fluid, which is positive for candida, is going to be high. So this is helpful mostly in the surgical patients, but this cannot be applied for the medical ICU. So another score that is commonly used in the medical ICU is the Candida score. And this is a simple scoring system that can help identify differentiating between the Candida species colonization versus Candida infections. I think a lot of participants were asking whether every colonization should be treated. So this score will help us to identify whether the patient has a colonization or it is a Candida infection, so that a preemptive treatment can be started in these patients. So the Candid score they've done a multivariate regression, and a weighted score was given for these independent risk factors, which is multifocal candidal species colonization has a score of 1, surgery on ICU admission has a score of 1, severe sepsis has a score of 2, and a parenteral nutrition has a score of 1. So if the score is more than 3, it indicates that the patient has a high risk of infection rather than colonization. And these are the group of patients who would probably require an antifungal therapy. So the validation of this score was done, and then it has been shown that with increasing score, the chances of patient having an invasive candidiasis is higher, and the mortality also is higher. So as we talk about positive colonization, there's a colonization index that helps us differentiate patients with a colonization versus a true infection. So here, the number of positive culture sites divided by the number of sites that are positive is done. And if the score is more than 0.5, it is considered as an invasive fungal infection, and you can start an antifungal. If the corrected colonization score, that is, this looks at patients with the sites that are highly colonized. And if the score is less than more than 0.4, we would consider that as colonization that would require an antifungal therapy. So as we have seen the earlier scores, they were all either the patient has a high risk for fungal infection or has a low risk, but then it's never yes or no all the time. There is also a middle gray zone, which is a maybe. So we need to actually stratify them in accordance to the score. So there are the subsequent scores have actually looked at different levels of prevalence and risk, and we will be going through those scores. So here is one risk score that has also included the newer strategies of identifying fungal infection, and also the newer strategies of identifying those with diminished immunity, like the CD8 count less than 143, which has a weighted score of 1. High dose corticosteroids has a score of 1. antibiotics has a score of 1, Apache more than 15 has a score of 1, BDG positive has a score of 1, and previous surgery has a score of 2. So here, this is the ROC, that is the area under curve. And it shows that the ROC for this particular score is better than the candidate score. And also this score divides the patients into low, moderate, and high risk depending on the score. If the score is between 0 and 2, it is a low risk. If the score is between 3 and 4, it is a moderate risk. And if the score is 5 to 7, it is a high risk. And then we can see that the incidence of invasive candidiasis increases as the risk of the score increases. And this is another scoring system that has introduced some novel biomarkers into the score. And here they have because fungal infections actually act on the immunity of the patient, the high neutrophil lymphocyte ratio has been introduced as a risk factor, and also the C-reactive protein to albumin ratio has also been introduced as a risk factor in this scoring system. And this is the weighted score points for each of these. And based on these, the patients are categorized into high, medium, and low risk categories. And also this score has shown to be performing better than the candidate score. And the positive predictive value though is low, but the negative predictive value of this score is high. That is, it will help us identify those patients who are not at high risk for developing a fungal infection. So if you look at the individual markers, as opposed to the ROC or the area under curve for each of these individual markers, the scoring model, which is a weighted model of all the individual risk factors together, has a better area under the curve. So as opposed to individual factors, the area under the curve for this is much better. So if you, a meta-analysis that is published recently has shown that there are several risk factors for fungal infections in the ICU. But then if you see, the odds ratio for most of these fungal factors is very low. And a few of these factors have a higher odds ratio. So though there are multiple scoring systems that have been developed, there is a lot of risk factors that have been identified in each of these scoring systems, and each one is different from the other. So this is a meta-analysis of all the risk factors together, which shows the odds ratio of each one of them. So at the present, probably we do not have one single risk scoring system that says that this is the scoring system that we need to use in the ICU. So there's a comparison of different scoring systems in the ICU that was done by SGPGI, and they have shown that the sensitivity and specificity of most of these scoring systems, that is the Candida score, the colonization index, and the clinical prediction score, were not very different. And if you see, most of them have a good sensitivity, but their specificities are low. Similarly, the negative predictive values of all these scores are higher, but the positive predictive values are lower. So these scores can be used to identify those patients who are at a lower risk for fungal infection, so that we do not overtreat these patients. But then we cannot really point out to those patients who are at a higher risk to start the antifungal therapy right now. So both the clinical scores as well as the laboratory tests have a higher negative predictive value, but then the positive predictive value right now for many of these scores is not really high. So they have, most of these scores and the biomarkers can be used to identify where we need to withdraw the empirical antifungal therapy, but then right now to start an antifungal therapy, they're not really very useful. So the currently used scoring systems are these: the Candida score, where you have a parenteral nutrition has a score of 1, surgery, and then multiple colonization and severe sepsis has a score of 2, and the cutoff for this score is 3. The colonization index has a cutoff score of 0.5, and the corrected colonization index has a corrected score of 0.4. The clinical prediction rule has major and minor factors, that is length of ICU stay, mechanical ventilation, antibiotic usage, the CVC lines, and surgery, immunosuppression, pancreatitis, TPN, etc. And then the cutoff for this is 5. So currently used systems in the ICU are these. There are several systems under development, but then none of these scores are really validated. So based on these scores, we can identify which patients are at a higher risk and which patients are at a lower risk. Starting antifungal therapy, again repeat the scores. So based on these scores, it has been seen that the number of patients treated has come down to 10 to 15%, and the number of candidiasis that is captured is also higher. So currently, the ESICM recommends the use of these scores because of the simplicity and also the high negative predictive values for, and they can also be used for identifying those patients who are at higher risk. So based on that, they have developed an algorithm for use of these scores. The ESICM algorithm for identification or for starting of antifungal therapy is like this. If you have a patient with sepsis, and if the patient has an abdominal sepsis, then there is a high risk. So we can consider invasive candidiasis or candidemia if the risk score is more than 10, and then start antifungal therapy and source control. In the meanwhile, send the blood cultures, especially if the likelihood of having a fungal infection is more than 25%. And also send for the BDG. And if the BDG is less than 80, probably we can consider stopping the antifungal. If there is no abdominal sepsis, and look at the risk of having a fungal infection, if the candidal score or the colonization index are high, then we can consider starting the antifungal therapy. But if they are low, do the biomarkers for fungal infection, and then we can consider whether we need to start the treatment or have a watch on this patient depending on the values of this. And if we are watching, reevaluate on the 5th day. So these are various markers that have been suggested by the ESICM for evaluating the patient for a risk for fungal infection, the BDG, the miniaturized magnetic resonance based technology that Dr. Uma was talking about, which can give us very early results, and also the antigen, the Mannan antigen and the antibody test, and also the Candida species germ tube antibodies and PCR, which Dr. Uma said is not very specific for the infections. So based on these, we can again decide whether we need to start the antifungals or have a watch on these patients. So right now we do not have one single score that is going to be very sensitive as well as specific, which have good positive and negative predictive values. So the algorithm that is proposed by ESICM still needs a validation. And in future, probably we can add things like MR into the algorithm to decide on the rational use of antifungals. So until then, we know that we have risk factors in the ICU, both the patient factors as well as the environmental factors. And prevention is probably better than having an infection and then trying to cure it. Thank you.
Thank you, ma'am, for an excellent talk. And the scores you have highlighted, the way to use them, the newer scores, and the way forward as well. There are a few questions in the chat box. Is there any role of procalcitonin in fungal sepsis?
No, procalcitonin is to identify those patients who are at risk for a bacterial sepsis. Probably we can do a procalcitonin to see whether the fever is a bacterial in origin, or if it is negative, maybe we can consider a fungal infection. But then again, we know that there are a lot of false positives and false negatives for procalcitonin, so that cannot be very reliable to identify those patients who are at risk for fungal infection.
And second question is, what empirical antifungal should be started in the ICU setting based on the scores?
Currently, the ESICM recommends either start of fluconazole or voriconazole as a empirical antifungal.
Thank you. Any other questions? May please be asked at this time. Our next question is, what are the prophylactic measures for the ICU setting?
Yeah, as I said, I mean, all the infection control measures that are required in the ICU are also useful for the fungal prevention of fungal infections. So probably it's the same thing as this slide shows. You can see that I think Padmaja is going to emphasize on these things. The hand hygiene, contact precautions, environmental screening, everything that you do in the ICU for infection control is also useful for candidal infections as well.
Thank you,
And
ma'am.
I think just as we have antimicrobial stewardship for bacterial infections, I think we also need to emphasize on the antifungal stewardship now, and then we need to be very judicious in using the antifungals.
Thank you, ma'am. There being no more questions, we move on to the next talk. And I have much pleasure in inviting Dr. Vishnu, who is a consultant ID physician at Apollo, Jubilee Hills, Hyderabad. A very passionate ID physician, and then we've heard him all. He requires no introduction. Over to you, Dr. Vishnu.
Good evening, one and all. Thank you, sir. Thanks for that kind introduction. So today I'm going to talk on management of invasive candidiasis. So essentially, I'm going to concentrate more on the treatment aspects. Already, the prior speakers have covered the epidemiology and the diagnostics and the candida scoring. There may be slight overlap, but I made sure that I'll be concentrating more on the treatment aspects. So before starting my talk, I want to present a case, the real case which happened. And I'm going to show what happened and how do we need to treat candida patients. So this is a 50-year-old female who's a diabetic in ward who had a Whipple surgery, was on cefoperazone sulbactam antibiotic following that surgery at day 6. She had lines, she has total parenteral nutrition, she has a catheter. At this point, she had fever, patient was unstable, and WBC counts were high. So X-ray was normal and ultrasound abdomen was no evidence of collection. So the primary team suspected it's a new bacteria, new sepsis. It's a nosocomial sepsis. They sent cultures and they started only on meropenem and teicoplanin. Now, yeah, sorry. Yeah, and now on day 8, patient was on ventilator. Patient progressed, and the patient was on ventilator, was on inotropes, and there was worsening renal failure, deranged liver function test. CT abdomen was suggestive of only minimal collection. So day 9 worsening status, and cholesterol is added, but then blood cultures already grown candida species, and now caspofungin was added, but patient culture was growing candida glabrata, but patient expired. This is a real case. What happened, which I happened to encounter when I was a student. So I just recollected the case and just I thought I'll keep it here. Now, what is the problem with this case? What errors happened in this case? Candida was not suspected initially, and the patient was started on antifungal, that is the echinocandin, once the cultures were positive. So when the patient developed the new nosocomial sepsis, the candida was not suspected, and by the time the culture grew, already 3 days, and when they started at that particular time, already it was late and the patient expired. So in fact, this is one of the reasons why we worry about candida, because once the candidemia sets in, the mortality is more. Just like your gram-negative sepsis, where we talk every hour delay in appropriate antibiotic, the mortality goes up. Like that only, candida also, every day delay in the antifungal initiation, the mortality goes up. So administration of antifungal after 3 days of candidemia, or once you suspect candida sepsis, the mortality can be as high as 40%. So first take home point is, whenever we suspect candida in a nosocomial patient who has sepsis, when you suspect candida, the treatment initiation should be early. It should not be delayed. So this is the message we need to take. And at the same time, you should not give antifungal to somebody who is not required. So I'm going to take you through my slides and say whom to choose and how to choose and all. So first of all, we need to understand what are the risk factors. Remember, patient won't come to the hospital with the diagnosis of candida. Patient comes to the hospital with risk factors. They have diabetes, they have malignancy, renal disease, steroids, and all that. And they have fever. For that, they get antibiotics. Once you give antibiotics, it kills most of your gram positives, gram negatives, and anaerobes. And that makes your candida to outgrow. So there will be selection of the candida. Once the candida selects, it colonizes. And once it colonizes, because of the breach in the natural defenses, that like breach in the skin or mucosa, or when you put a line, when you open the abdomen, when you open the gut, so it spills, and that may cause candidemia. So patient comes to the hospital with some problem, gets antibiotics, gets instruments, gets lines, gets Foley's, and have intra-abdominal surgery, immunosuppressed, and then Candida colonizes and then invades. So this is how it happens. So keep in mind that most of the times patient won't come from with Candida, invasive candidiasis from the community. So keep that in mind. So as I told you, with all these risk factors, they get antibiotics, Candida selects out, and with the mucosal damage or inflammation, then the Candida invades and causes invasive candidiasis. And now, one of the most important thing is that once the Candida enters the blood circulation, it can seed. The commonest thing it can seed is that eye. So once the Candida is in the blood, and the longer the duration of candidemia, the higher is the chances of seeding. So Candida can seed in the eye and it can cause chorioretinitis. It can seed in the liver and spleen. This typically happens in a neutropenic patients post-recovery hepatosplenic candidiasis. It can seed in the kidney also. It happens typically in the neonates, and it can also seed in the lungs and also in the bone. So Candida can seed once it enters the blood, it can seed in multiple organs. When it comes to an adult, the commonest site where it seeds is eye and then heart, endocarditis, especially when this persistent candidemia, you need to think these things in mind. And one of the most important thing is Candida forms biofilms. And whenever you have a line related candidemia, the success rate is most of the times by removal of the source. That is, removal of the line is most important. Just pumping on antifungals not going to help, and addressing the source, because Candida forms biofilms and you require to remove the focus for us to have a optimal good outcomes for the patients. Now, so Candida can be two types. One is the candidemia, and then the others are the deep-seated candidiasis. In the deep-seated candidiasis, most of them, what we see is the intra-abdominal candidiasis because of the anastomotic leak or pancreatic necrosis or recurrent GI perforations or surgeries. And the other forms are because of the seeding, as I was telling, seeding in the eyes, lungs, bones, and so forth. Now, what are the risk factors? As I'm already telling that the risk factors are many, like kidney failure and total parenteral nutrition, surgery, and antibiotics, and foreign bodies. All these are the ones. Those are the risk factors. Now, what are the antifungals that are available? These are the risk factors. Now, what antifungals are available for us to treat? We have these echinocandins. We have echinocandins which inhibit the beta-glucan synthesis and can inhibit the cell wall. You can have polyenes which bind to the cell membrane, and you have azoles which inhibit the synthesis of ergosterol, and you also have flucytosine which inhibits the DNA synthesis. These are the drugs. These are the medications that are commonly available. And now, already the prior speaker has spoken extensively on the Candida scores. One point I want to tell that, see, these prediction scores, whatever are there, they have good negative predictive value. If I have a patient in hospital, if the patient develops nosocomial sepsis, these risk prediction scores help me to identify the risk, whether this patient is at risk of having Candida. This will identifying the risk, and most important that these have good negative predictive value. That means that in the absence of these risk factors, the Candida being invasive candidiasis is unlikely, but with the positive predictive value is less. So keep that in mind. These are good. All these Candida scores has a good negative predictive value. Please keep that in mind. Now, what is the problem? See, most of the times, the blood culture, one of the main issues what we face is that most of the times blood cultures may not grow. Even if you see the literature, only up to most of the times, if you see more of the literature, 50% of the time only the blood cultures grows. And mind you, the blood culture doesn't grow if you send only one bottle. Whenever you suspect a nosocomial sepsis, which including Candida also, 2 sets of blood culture should be sent. 2 sets means 4 bottles, one aerobic, one anaerobic, one aerobic, one anaerobic. So this optimal amount of blood is required. And even with that good, then only most of the times, 50% of the time only, we grow the blood culture. So that is one of the issues we have with Candida. In fact, that's the reason we have all these biomarkers come into play, and which help us to identify Candida. So now there are few concepts here. There's something called as prophylaxis therapy, preemptive therapy, empiric therapy, and targeted therapy. See, prophylaxis means fear-driven. Fear-driven means that the patient a patient is in the ICU with sepsis because of some other reason. Say this patient has bacterial sepsis, this patient has abdominal surgery, and now because his risk factors, he is at risk of having a Candida infection later. So at that time, what you give to prevent the patient from future developing Candida because of his risk factor, that is called prophylaxis therapy. Preemptive therapy is that biomarker based. See, typically this preemptive therapy we use in most of the times in real life, what we in certain centers where you use in a post hematopoietic transplant, where every 2 weeks they do these markers to identify candida, to identify the invasive fungal infection before they develop signs and symptoms. And when it comes to empirical therapy, that means patient is in the hospital because of some reason. Now they develop new sepsis and they already have symptoms. So when you start the treatment once after the onset of symptoms, that is called empiric therapy. And the directed or the targeted therapy is that once your culture grows, that is what is the directed or targeted therapy. So simple words, prophylaxis is the fear driven, preemptive is the biomarker driven, empiric is the fever driven. That means already the patient has developed the symptoms, and cultures is like final once the culture goes. So these all strategies what we have. And mind you, this prophylaxis strategy most of the times we use in our hematological patients, that is neutropenic patients, or somebody with a post hematopoietic stem cell transplant patient, autologous, allogenic. These are the patients where most of the times we use this prophylaxis, because we not to prevent it from future getting candida. Now, empiric treatment is what we use in most of the ICUs, and I'm going to show what the recommendations say in a non-neutropenic host. So in empiric treatment, we have three things. We have proven, we have probable, and we have possible. Proven means it's a culture proven or the tissue proven candidiasis, and probable is whenever you have a nosocomial sepsis, it is biomarker driven. That means here the patient has sepsis episode, you send the blood cultures, you send the beta-D glucan, mind your blood cultures negative, and the patient beta-D glucan is very high, and you treat the patient. That is probable. And possible is that, you know, patient is in sepsis, septic shock, and the cultures negative, and your negative biomarkers, but you put on the treatment, they get better. So now most of the centers, if you see, most of the centers, beta-D glucan is not available, and is most of the times it is possible what happens in the real life. You know, nosocomial sepsis, they send the cultures, they start on the antifungal, they get better, cultures gets negative because of the response they treat. So that's how we do it. Now, we need to move from this possible to probable, because in possible, where you don't have any evidence of fungal infection, there is chance of having you end up in treating over treatment, and hence the resistance. So the best thing now is to move towards the probable, because as we know that proven, the problem is that not everybody grows. So the best thing is to move from possible to probable based on certain certain markers like galactomannan, which help us in better identification of our patient and better treatment of our patients. Now, so what does the recommendation say? I have taken two recommendations. One is the ECMID recommendation. The other one is the IDS recommendation. ECMID recommendations are more recent, 2019. So what are the what is the role for using these risk prediction models? What is the role for routine prophylaxis? What is the role for preemptive prophylaxis? See, mind you, this risk prediction model they have a high negative predictive value, and they should be used for identifying the risk group. So that is the most important point here. And next statement is that there is no role for routine universal prophylaxis in ICU setting in critical patient, and also there is no recommendations for using preemptive treatment. Mind you, there is no role for routine antifungal prophylaxis in a non-neutropenic ICU patient, and also there is no recommendation on preemptive treatment. So always keep that in mind. So you cannot just, somebody comes with the admitted in the ICU, put on the ventilator, you cannot just put them on fluconazole, and there is no role for routine preemptive treatment. So most of the times it's empiric, and based on the, and we need to titrate it with the, we need to identify the, with the cultures and the serum biomarkers, we need to base our treatment. So this slide has already been shown here. When somebody comes in nosocomial patient with sepsis, and if they have risk group of candidemia, if you suspect candidiasis, look into the likelihood, look into the scores, and as I told you, they have good negative predictive value, not positive predictive value. If these patients have good risk factors, and start the patient on empiric antifungal therapy, send 2 sets of blood cultures and beta-D glucan. See, the advantage of beta-D glucan is that it has good negative predictive value. You can very low value, you can essentially rule out candidemia. So essentially what it translates is that when you suspect a patient, when a patient is in the hospital with the risk factors, you suspect candidemia, you send the blood cultures 2 sets, you send beta-D glucan, you start the patient on antifungal, and what you do is that you wait for your beta-D glucan and the cultures, and say if the culture is negative, say beta-D glucan is very high and the patient responded to treatment, you're going to label it as probable candidiasis. Say if the culture has grown something else, your beta-D glucan is negative, so you're going to rule it out. And always reevaluate on 5th day and look for the other sources, and then you take a call. So this is what we need to understand from this slide. Now, this is, as I told you, there is no role for routine prophylaxis and preemptive therapy. And when it comes to the empiric therapy, what is the algorithm? When the patient is in the hospital, nosocomial sepsis, all these risk factors, patient is hemodynamically stable, then the drug of choice, if you want to treat for candidemia empirically, is the echinocandin. Echinocandin is the drug of choice for hemodynamically unstable patient. Even for stable patient, if it's available, always echinocandins are preferred. You may get away with fluconazole if there is no prior no prior azole exposure, because presence of prior azole exposure is the factor for azole resistance. So if there is no prior azole exposure, and if there is not much of azole resistant in your center, and if the patient is hemodynamically stable, you may start with fluconazole. Otherwise, it is echinocandin. And now, once you start on the echinocandin, if the culture do not grow, but the patient gets better, treat for total of 2 weeks. For example, if the culture did not grow, your beta-glucan is negative, and patient did not respond after 4 to 5 days of treatment, then stop that therapy and look for the cause something else. Now, what if the culture grows? You know, as I told you, we suspected candida, we standard on echinocandins. Once the culture grow, the total every day, every alternate day, you need to ask the cultures, and treatment duration is for total of 2 weeks after the final culture negativity, number one. And all the patients with candida, you need to do a dilated ophthal examination to look for seeding in the eye, because if your eye, there is seeding in the eye, the treatment duration varies. And the other important thing is, whenever you have a line-related candidemia, you should and must address the source. Otherwise, the patient is not going to get better. And can we de-escalate once the culture has grown? Yes. You can de-escalate at day 5 to day 7 if the organism is azole susceptible, number one. If the patient is hemodynamically stable, number two. Number three, if you have removed the source, after 5 to 7 days of echinocandin, you can step down to fluconazole and you can treat for go for total of 2 weeks of treatment. So these are the things you need to remember. So this is what the same IDSA and ECMID said the same. And one of the important thing is, always try to remove the catheter. If it is an extremely precious line, if you are not able to remove, at least it takes 1 or 2 days for you to remove. You know, always do not de-escalate if you're not able to address the source. Always use echinocandin if you're not able to remove the source because of its better penetration into the biofilm. And the alternative other than echinocandin is the liposomal amphotericin B. Liposomal amphotericin B we only use if you can't use echinocandin or azole because of some other reason. Otherwise, the always drug of choice is echinocandin. Now, the treatment duration is for 14 days, as I told you. These are the things you need to, both IDSA and ECMID both says to treat for 14 days from the large culture positivity. Now, so this is a simplified slide where you can see for all candidas, if the preferred initial therapy, if you see here, it is echinocandin is the drug of choice. The alternative, if the patient doesn't have azole exposure, or if the patient is hemodynamically stable, the alternative therapy is fluconazole, and for candida glabrata, alternative therapy is amphotericin B. And mind you, cruzi, most of the times it is azole resistant, fluconazole resistant. So the alternative therapy are ampho-B or voriconazole. And when you step down, once the patient gets better at 5 to 7 days, hemodynamically stable, then the step down therapy is fluconazole, except for candida cruzi and candida glabrata, either it is high dose fluconazole or voriconazole. And for its candida auris, it depends on the susceptibility. Most of the times, auris is almost always resistant to fluconazole, and it may, if you're lucky enough, if it is voriconazole sensitive, then you may step down to voriconazole. Otherwise, the same echinocandin you need to give for total of 2 weeks. Now, so what about in the hematopoietic stem cell transplantation? Still, ECMID recommends for candidemia, the drug of choice is echinocandin, and for candida prophylaxis, micafungin is approved for both the treatment and for prophylaxis. Now, few other important things what we encounter in the routine practice is the candiduria. Mind you, most of the times candida in the urine is colonizer. You routinely send cultures for something else, patient is absolutely fine. All you need to do is change the Foley's. Treating doesn't help. When you treat candiduria, there are only 3 indications. Neutropenic, somebody with very low birth weight, and whenever you are doing a new urological procedure, your patient is planned for urological procedure, your urine is growing candida, then you need to treat, because when you manipulate the mucosa by doing a procedure, it can spill into the blood and can cause candidemia. Candida in the respiratory tract also, it is most of the times it is almost always colonizer. You hardly get candida pneumonia. So these are the 2 things where it is most of the times colonizer, not treatment. These are the things you need to keep in mind. Now, there are different deep-seated candidiasis, and how long to treat is what I'm going to discuss here. So candidemia in neutropenic patient is same like in non-neutropenic host, 2 weeks of therapy, 5 to 7 days step down therapy, 14 days treatment. except that you need to understand that in neutropenic patient, the source of candida can be even gut. So central line removal may not be always required. So it will be depend on case by case basis. One of the important thing is that ophthalmological examination we do after 1 week of neutrophil recovery, because neutrophils are required to form those changes in the eye for us to visualize. So ophthalmology examination after the neutrophil recovery, not before neutrophil recovery. So these are the points you need to remember. And hepatosplenic candidiasis, this is one of the candida where we see in neutropenic patients, once the neutrophil recover during the neutropenia, they have candidemia and they see it in the liver and spleen. But initially you don't see signs because they don't have neutrophils to show those signs. Once the neutrophil recover, you see them as hepatosplenic abscesses. So these are the one where you treat with echinocandin initially, and then later you may treat this for months till there is complete radiological resolution. Typically you see in the neutropenic patients. So the treatment is for longer duration. Now, when it comes to infective endocarditis, the treatment is a combination of liposomal amphotericin B and flucytosine or high dose echinocandin, where you give 200 mg of anidulafungin or 75 mg of 150 mg of caspofungin for these patients. And once the patients get better, you can once the culture is negative and it's susceptible, you can step down to oral fluconazole. And the treatment is for, and valve replacement is a must. And after valve replacement, at least 6 weeks, you need to treat. And next is a candida suppurative thrombophlebitis, where you will treat for 4 to 6 weeks, and catheter removal and incision drainage or the resection of the vein, if it is required, we need to treat. And at least 2 weeks of echinocandin followed by step down therapy of fluconazole is what we're going to use. When it comes to the candida osteoarticular infections, if it is a osteomyelitis, it is for 6 to 12 months. If it is septic arthritis, mind you, you should do source reduction, and minimum of 6 weeks is the treatment of choice. And candida endophthalmitis, it is always most important here. Here we don't use echinocandin because echinocandin doesn't penetrate the eye. So if you have only chorioretinitis without vitreitis, you can treat with fluconazole or voriconazole if it is azole sensitive. If it's azole resistant, then you need to do liposomal amphotericin B. And you're going to give intravitreal injection if it is vision threatening. If the lesions are near the macula, then you give intravitreal ampho or voriconazole. And with chorioretinitis with vitreitis, then above treatment plus intravitreal injection you give, and also you may do a vitreectomy to reduce the fungal burden. So mind you, this is one place where we don't, one of the places where we don't use echinocandins because of the poor penetration. Mind you, echinocandins doesn't penetrate good into the eye, into the brain, and into the urinary tract. These are the places where echinocandin we don't prefer because of its poor penetration. Now, CNS candidiasis, as I told you, this is other place where you use liposomal amphotericin flucytosine. You don't use echinocandin because of the poor penetration. And devices should be removed, and we're going to treat till complete resolution, and we're going to remove if there is any devices also. Now, candida in the urinary tract, as I told you, it is azole or conventional amphotericin B. Mind you, this is one place where we use conventional amphotericin B. We don't use liposomal amphotericin B because liposomal amphotericin B also doesn't penetrate well into the urinary tract. And echinocandin also doesn't penetrate well into the urinary tract. So when you use here, you use azole fluconazole or conventional amphotericin B or flucytosine. So these are the drugs which has good penetration into the urinary tract. So keep them in mind. And final thing is the neonatal candidiasis. Even in neonatal candidiasis, echinocandin is not the drug of choice because neonatal candidiasis, candidemia, most of the time is seeds in the brain. So that's the reason, conventional amphotericin B, amphotericin B is recommended, and fluconazole is an alternative, and liposomal amphotericin B also they can use, only they avoid it if there's renal tract is involved. Echinocandin only in few cases, because in neonatal candidemia, it goes to the eye, it goes to the meninges. So that's the reason people tend to avoid using echinocandin, and all the neonatal patients who has candidemia should have eye examination and CSF analysis. So these are the points which we need to know. I think with this I end my talk. Thank you. I would like to take if there are any questions, please.
Thank you, Dr. Vishnu, for a wonderful presentation. You very well highlighted both the clinical scenarios, how to use the scores, what type of therapy is there, and the different sites where the treatment of the drug may vary and the duration may vary. I'm sure everybody is really crystal clear about this. Thank you so much for the talk. A few questions are there in the chat box and from me as well. With respect to antifungals, what would you look at while using either echinocandins or azoles with respect to hepatic and renal issues and drug interactions?
Yes, sir. Sir, echinocandins are very safe drugs, sir. We can very well use in liver issues and kidney issues, except caspofungin. Caspofungin we tend to avoid in somebody with a childpox C. There is some dose recommendation, but I tend to avoid echinocandin, caspofungin in childpox C, but we can safely use micafungin and anidulafungin. This is from the echinocandin standpoint, sir. When it comes to the azoles, all of the azoles they go through the liver, and azoles we don't use if there is a severe renal failure. So any especially the voriconazole, posaconazole, we tend not to use if somebody has a liver failure because of their metabolism through the liver. And amphotericin B you can safely use in liver issues, but amphotericin B has a problem of nephrotoxicity, so there we need to be careful. And what is the other question, sir? What is the other question, sir?
Yeah. Drug interactions with azoles.
Yes, yeah. Drug interactions, sir. Azoles are the one which has highest drug-drug interactions, especially in the post-transplant setting. Most patients will be on tacrolimus. So whenever they are on tacrolimus, post-transplant setting, whenever you use voriconazole, always check the drug-drug interactions, always check the tacrolimus levels. And also if the patient is an endocarditis patient, if the patient is on valve, when the patient is on warfarin, please check for drug-drug interactions. And you cannot use azoles, especially voriconazole, along with the tuberculosis treatment because of the rifampicin. So these are the common interactions where we face. So especially when somebody is on azoles, we should always check the drug-drug interactions.
Yeah. Question from Dr. Vishal Gupta. How to decide which echinocandin to use? Micafungin, anidulafungin, caspofungin, any particular reason of use?
Excellent question, sir. Or as per recommendations, all echinocandin are equally effective. There is no study to say that one is benefit over the others. Probably I will choose based on the scenario. For example, I will choose more of a micafungin in hemopoietic stem cell plating because that is the one which is well studied. That is the one which is well studied for the prophylaxis. When it comes to the liver transplant patients, I tend to use anidulafungin because that is the one which is well studied, and that is the one which has the least drug-drug interactions. If you take caspofungin, there is some drug interaction with sirolimus, but anidulafungin is the one which is least drug-drug interactions. So otherwise, most of the times it is the almost all are equally effective.
Next question from Dr. Irfana. The Candida prosthetic joint infection management and duration of treatment of Candida prosthetic joint infection before a second stage revision can be done.
Yes, sir. So when somebody has a Candida prosthetic joint infection, the treatment should be first is we need to have the culture. Treatment is for minimum of 6 weeks, and then implant removal minimum of 6 weeks, and then spacer, and after that you're going to put a new implant. So minimum of 6 weeks of antifungal before putting a second implant. In fact, we're going to wait up to 3 months. But minimum of 6 weeks is the treatment. Drug of choice is echinocandin for at least 2 weeks. And then if you're lucky, if you're azole susceptible, then you can go for fluconazole. And once you put a new implant, there will be chronic suppressive treatment with the azole to prevent the reinfection.
A question from Dr. Uma. What has been your practical experience with Mannan, anti-Mannan and the BDG, and how often you have encountered false positive with BDG?
Yeah, I think it's a very good question, ma'am. First thing is that we have extensive experience with beta-D, 1,3-beta-D-glucan, ma'am. Our center do not have Mannan and anti-Mannan, so I cannot comment on it. When it comes to the beta-D-glucan, it has an excellent negative predictive value. It has lot of false positives. And most important thing is a very high value has a role, very low value has a role. Most of the times, if the problem happens is when the clinician asks without having a pretest probability. So when my pretest probability is low and the beta-D-glucan is negative, fine, I can rule it out. When my pretest probability is little high, but the beta-D-glucan negative, that also gives me fair confidence this is not Candida. But when my pretest probability is low and if the values are in between, that is what happens most of the time. When the values are between 80 and 500, that is the time where we need to take a clinical call. Because lot of even the normal bacteremias can cause false positive beta-D-glucan, and this gauze species, albumin infusions, there are a lot others which can cause this false positive. So it has to be interpreted in the clinical context. Yes, there are a lot of false positives, and most of the time the real problem is that intermediate values, which has to be interpreted in the clinical context. The best usage is very high values, very low values, has very good this thing, and in between values are always we need to interpret with the clinical scenario.
Yeah. Question from Dr. Priyank: is antifungal lock an option to salvage a catheter?
Generally, antibiotic lock we try to use for less virulent organisms like coagulase negative staph or certain ESBLs. We try to avoid antibiotic locks if it is staph aureus, number one. Number two, candida. And number three, extensively drug resistant organism. Because what happens is if I try to salvage the catheter, if I lose the lock, the longer it takes time, because when you don't address the source, the duration of candidemia is more. When the duration of candidemia is more, I'm going to that's going to seed in my organs. So always, whenever it is possible, please remove the line. Antibiotic locks are not well studied for this, and that is the least thing I will do, and I'll do it as a last resort when nothing else is there. But in general, no.
Last and final question for you: post-transplant asymptomatic candiduria, do we treat? Question from Dr. Ravi Teja.
Yeah, post-transplant in the sense which transfer? If it is in general, even in all the solid organ transplant, there is no recommendation. It is recommended not to treat asymptomatic bacteria. There is one place is the post-renal transplant. Post-renal transplant, there is a discrepancy. Though a lot of data says that there's no need to take asymptomatic bacteria post-transplant, but most of the nephrologists do not agree, because immediately post-transplants, your patient is on a lot of immunosuppression and patient will be on stent sitting there. So that's the reason most of the renal nephrologists err on the side of treating the patients, because they won't mount and you have a stent foreign body and it can stick to that. So if you ask as per the recommendations, no. Post-renal transplant also enough data to say no required for treatment. But in real life, most of the nephrologists do not agree. They still treat in the post-renal transplant asymptomatic bacteria.
Yeah, thank you, Dr. Vishnu, for an excellent presentation as well as great clarity in answering all the questions. I hope to everybody's satisfaction, and thank you for being here in this session.
Thank you, sir. Thanks a lot.
Yeah, I think we come to the last talk of the session, and it's already 9:30, so I promise to be very brief. Is the slide visible?
Yes.
Yeah. After having very heavy duty talks on all the aspects, mine is a very simple talk, very short talk, I promise, on prevention of healthcare associated invasive candidiasis. No, we've always dealt on the risk factors by multiple speakers, but I will go through them because each risk factor we can actually look into as a potential prevention strategy. For somebody who's with a critical illness with a prolonged ICU stay, so during our everyday rounds, we need to be very careful. Is the patient still required in the ICU, or is he fit to be shifted down to a step-down unit? Indwelling central venous catheter. Actually, I spent quite a bit of my talk on the central venous catheter, how to put, what to put, when to remove, how to clean the skin before putting a catheter, and how it goes a long way in prevention of fungal infections. Weakened immune system, we've already discussed transplant, chemotherapy, neutropenic patients, multiple abdominal surgeries, including anastomotic leaks, prolonged and multiple antibiotic use in the hospital. That is a very big risk factor, as the first speaker also started this off. TPN, chronic kidney disease or patient on hemodialysis. Then obviously the risk factors like diabetes, preterm babies, and the injection drug usage. Now, ICU stay, as I said, we need to daily, during a round, see whether this patient can be shifted to a step-down unit or a ward, because every time person stays longer than required in ICU stay is at a risk of infection. Coming to central venous catheter is a very important source of invasive candidiasis. We'll go over that, including the placement, maintenance, removal, and the class B, that is the central line associated bloodstream infections. Today being the World Hand Hygiene Day, we'll spend a short time on hand hygiene. Then aseptic cleaning of patients within the ICU, rational antibiotic use and the courage to de-escalate based on the cultures, antifungal prophylaxis. I think Dr. Vishnu already spent some time, so I won't spend a lot of time on that. And then clinical scores, we've already discussed, a couple of speakers talked on the clinical scores as a prediction for candidiasis, and therefore we need to be quite alert and then start therapy if the scores are actually pointing to a high risk. Coming to the central line, which I will spend quite a few minutes on. Few basic things would be insertion and care should always be performed under sterile conditions. A lot of times we see that somebody is already in their shirt, trouser, etc., coming from the OPD with a tie and then trying to put a central line. I think the care to put a central line should be something like you're doing some surgery in an operation. You need to scrub properly. You need to put your gown, your mask, your cap, drape it properly. And as you do in a surgical OT, that is the way you should put a central line, because some carelessness here can be a nidus for infection, and that can be a totally iatrogenic source of invasive candidiasis. So I strongly urge everyone that take central line insertion as almost as a OT procedure, and then take equal precautions while you're doing that in an ICU setup. For skin cleaning, again, betadine, etc., is not recommended, and 2% chlorhexidine containing solution is what is most important here. Again, antibacterial preparations on the site after insertion a catheter around the tip, which we put mupirocin, etc., are not recommended in general. Maybe they'll have some place in the hemodialysis catheter section. What kind of dressings we use is important, because they need to be a bit semi-permeable. They need to be transparent to see if there is some infection brewing there at the site of insertion. And the routine care of central line is very important. Quite often we find the line is left open, lying on the pillow directly. It is getting contaminated. Caps are not there. The blood which has been drawn is actually clotting the line. So proper care of central line is very important. And probably in some settings, a chlorhexidine impregnated sponge dressing is probably what is required for a central line dressing. This slide actually depicts a few steps of central line insertion bundle. Hand hygiene is important in any microbiological discussion, particularly so in our today's talk on World Hand Hygiene Day. And then maximal barrier precaution. You can see the person who's draped himself as in a OT, and therefore you can prevent. Even the place where you are going to put it is properly covered with a sterile cloth. And then daily review the line if it is necessary. And the site which you choose again should be preferably a site like a subclavian rather than a femoral site. And then scrub the hub before you actually start drawing samples or giving an injection. So this actually summarizes how a central line should be put and then taken care of as well. So to prevent the catheter central line associated bloodstream infections, first of all, we should avoid central line just because the patient is in ICU. If you have a peripheral access, not on heavy dose of inotropes, and a peripheral line is available, that should do the job. Second would be selecting a catheter. As I said, subclavian catheter is important rather than a jugular or femoral site. Again, the number of ports should be minimized. Just a minute. Avoid a triple lumen if you can get away with a double lumen or a single lumen catheter, depending on what you want to use the central line for. Hand hygiene on this day is very important. And avail all opportunities of hand hygiene. That is, before you drape, before you put the line, at all times when you are using the central line, either for medication, drawing a sample, use sterile gloves. And then a lot often we see that after the cleaning is done, people try and palpate the vein they're actually going to insert. So you should strictly avoid, because you just clean the area. You don't want to contaminate the area again by palpating the same. As I said, use maximal sterile precautions like the mask, cap, gown, sterile gloves. Prepare the site, the skin contamination, because Candida does colonize in the skin there. And then if you clean it with 2% chlorhexidine solution, a lot of preparations are available. That is a very important step in preventing catheter-related infection there. And if somehow there is a contraindication to chlorhexidine, then you can use 10% povidone iodine or 70% alcohol and let that dry before you actually place the catheter. And the dressing, I said, if the dressing is fully impermeable, that can actually prevent the moisture from hitting away and can serve as a nidus for candida. So either a gauze dressing or a semi-permeable dressing, which is transparent, is a very good thing. And once you inspect the catheter daily while we are doing your rounds, if the catheter side dressing is wet, it is soiled or it is dislodged, you need to change the dressing. If it is a gauze dressing, at least every 2 days you need to change, and semi-permeable dressing at least every 7 days. And then monitor the site for any source of infection. And if they have tenderness, infection, fever without any other obvious cause, remove the dressing and see. And if required, the catheter probably then needs to be removed. Hand hygiene is very important. You need to bathe the ICU patients every day with chlorhexidine preparation on a daily basis to prevent colonization, which actually serves as a nidus. The access port should be scrubbed with friction immediately prior to each use, and change the administrator sets for continuous infusions no more frequently than every 4 days, and for blood products or a fat emulsions for 24 hours. Only it is propofol where you need to change the tubing for every 6 to 12 hours. And then, as in an ICU patient, you are seeing whether the stay is required. Also for the central line, you please see whether the central line is required. Don't keep the central line because it gives you easy access for blood drawing. You may have to prick the patient more often, but a removal of central line when it is no longer required and a peripheral access is available is the norm. Sometimes in very special situations, you might have to consider antimicrobial or antiseptic impregnated catheters, but there's not much evidence actually with these. Hand hygiene, daily inspection, and removal of line for no longer when it is needed is actually going to help you. For healthcare organizations, it is very important that all the staff in the ICU are actually trained in taking care so that they do not inadvertently touch, contaminated the line, and they're also aware of the procedures, and they treat central line insertion, maintenance, and removal as a very sacrosanct procedure, because that can actually save lives. So even during emergency, whatever the kind of emergency, you still have enough time actually to just clean the area properly, drape yourself, and then use appropriate barrier dressing so that you do not contaminate, because one infection introduced at the time of catheter insertion may actually be fatal for the patient. Next, just wanted to highlight regarding Candida auris, but the former speaker has already told it is a very emerging infection, started in 2009 and it is rapidly prevalent now. It is a multi-drug, very often becoming more common. Problem is it is not correctly identifiable. A lot of hospitals don't identify fungi. If they identify fungi, they don't have speciation. If they have speciation, auris is very difficult to identify. And once an outbreak is there, it does not leave your hospital or ICU for maybe years together, and then all patients can be actually infected, and that becomes extremely difficult to manage these. The kind of antimicrobial or antifungal solutions which are there to sterilize that area are also not very well established. There is a website which I will show you where you can have information if there is a Candida auris outbreak. So we need to notify the local authorities when the Candida auris is there and work with a lab which is well versed in treating and preventing the cross infection for Candida auris. Patients ideally need to be isolated in an area where they don't have a risk for other infections, provided that area is safe for them to be managed for the medical condition. So transmission-based precautions wherever possible in a single room is preferred if you have a Candida auris outbreak. Hand hygiene is to be reinforced. And if you don't have that kind of facility wherein single rooms are available, within a large room, you segregate at least by about 3 feet different cots, and each patient should be managed with the same precautions as if they are living in different rooms. So especially your mobile and reusable devices like blood pressure apparatuses, then you have sometimes torches, sometimes stethoscopes, your glucometers which are used for multiple patients. they need to be cleaned between patient use so that that is not transmitted from one patient to other. So in summary, the most important steps to prevent and control invasive candidiasis would be compliance with hand hygiene before and after contact with patient, avoiding unnecessary invasive catheters, observing maximum barrier precautions during CPC and urethral catheterization, avoiding unnecessary antibiotic administration, and then stopping or de-escalating antibiotics when they are no longer needed, enteral feeding as soon as is possible, not only in terms of infection prevention, but it's also good for the gut that you start enteral feeding at the earliest, and then giving appropriate antifungal prophylaxis in high-risk patients. That is, we've already discussed, the high-risk patients would be neutropenic, stem cell transplants, or those undergoing chemotherapies, or the low birth weight infants. This chart has already been discussed, and for prophylaxis, we can use fluconazole 800 milligram loading dose followed by 400 milligram twice daily. Alternative can be an echinocandin. Thank you for the patient hearing, and I feel prevention is so much better than healing, because not only it saves you the cost, but it also saves the labor of being sick for that particular patient. So prevention of fungal infection should be a high priority. Thank you. Dr. Pankaj, I think you need to unmute yourself.
Thank you very much, Abkari, for a very illustrious talk, covering the practical aspects which on a day-to-day basis we need to practice in our ICUs. Any questions? People are welcome.
Dr. A.K. Gupta has his hand risen. If there is any question, Dr. Gupta, I'm happy to answer.
I think it's rather late.
Yeah.
And people must be hungry.
Yeah.
So we can close the session, and back to you, Dr. Abkari, for the final.
Thank you so much. On behalf of Indian Medical Association, the academic wing, Academy of Medical Specialities, Association of Physicians of India, Hyderabad chapter, and the ICMR Advanced Mycology Center of Nizam's Institute of Medical Sciences, I would like to thank all the speakers for being here, giving excellent presentations, which has been useful for all the audience, and created awareness among the fungal infections. And we've been updated and had great learning points regarding the epidemiology, emerging fungi, how to treat and manage candidiasis, the lab diagnostic test, and the preventive aspects as well. I would like to thank Dr. Uma for initiating this, and I'm sure this is the first of a series of programs on fungal infections, and IMA and API would be happy to associate and then take this message of controlling fungal infections, which are a high cause of morbidity and mortality in ICUs across the world and including India. And then knowledge about them is very limited. And thank you for taking the initiative. I would like to thank our chairperson, Dr. Pankaj, for being there all throughout the program and then guiding us and encouraging us in all our academic programs. I would like to thank Dr. Nawal, who's had to leave, for being there and then encouraging from the API Hyderabad chapter side for the academic program. We have this academic program. The next in the series will be informed to all of you in the various groups of API, IMA, etc. And if you wish to have any information regarding this program or other programs, we hope to have this program YouTube link on our website of Indian Medical Association, Academy of Medical Specialities, where you can have that. And if you're not an already member of IMA, please become one. And then please join the AMS, which is an academic wing, where you have excellent activities conducted not only by the headquarters, but also by the different states on a very regular basis. We also have a newsletter which is available on our website, which details our activities, and request all of you to make the best use for this academics. Thank you, one and all.
Thank you.